So I'm actually excited to be following Kevin because he showed us some of the stuff that I'm doing that I want to talk a bit about today, because I am a big fan of those fiber tacks that he's using as well, but there are some guidelines that we have to be careful about. My disclosures. Now, I met Gordon in 2011, like a lot of us did, when he first came and taught me about internal brace. And it's really expanded how I think about things and where I feel like my patients have to go and have to consider doing these repairs. So obviously I was asked to talk about the shoulder, but the thing is, it's way beyond the shoulder, as we've seen in the past 2 days. You know, at this point, I feel like this AC repair is an internal brace. That's all it really is. You know, I've shown you what I can do in the rotator cuff using biological braces, internal braces, static braces, dynamic braces. There's different things that we can do. The problem I see is where we're going. Like, I still can't quite wrap my head around doing anterior posterior stabilizations in the shoulder. Is there a way that we can actually do this without over tightening, causing increased joint reaction forces and cartilage damage? And of course, if things were too loose, that would be not good. So this is something I think that is definitely something we can be thinking about for the future of where to go in shoulders. But for me, one of the things that's been a big deal is this concept of permanent versus temporary fixation. And this has kind of changed up how I think of things. And this is Gordon's video from all those years ago where he showed us. And if you notice, the original concept holds true, and we still do this using a fiber tape and SwiveLocks. And yeah, this is Gordon's video, and he's got a great talking through on this. But the thing is that the internal brace loosens up. And that's because that SwiveLock that we've all used is a biocomposite anchor and will loosen up, and it will allow that fiber tape to become looser and be able to open up over time, which I think is critical to the actual healing of the natural biology. We're just protecting it, allowing it to heal. It's not meant to be there forever and replace like some static ligament in place that's a synthetic. That's not the point. So back when I started doing these remplissages, kind of these pasta bridge styles, what I was doing was a double pulley. So I'd put in these, sliding anchors, doing a double pulley, interconnecting it with a knot, and then taking it to a SwiveLock laterally. That was great. That was a pasta bridge concept. This was being done on remplissages, on pasta repairs, and things like this. But there was 2 points of loosening. There was the knot, which will loosen, and the SwiveLock, which will loosen, allowing the tissue, once it heals, to take over and do the work it's supposed to do. And this is what we would see. This was great. The problem is that we started getting these new knotless fiber tack type of anchors where the fixation was fantastic. I am not trying to rip the anchor. I love the anchor. The problem is it created a problem for me. So I started doing these interconnected type of repairs where I would go ahead and pass, just like you saw Kevin do today, which I do think is a fabulous method to do it. And being able to interconnect things and pass a suture from one to the other and hold in place was wonderful. Doing it knotlessly, requiring no further SwiveLock beyond. And that was great. And this is how it works. Simply passing one suture to the other, having it connect down, interconnected, and then simply pulling and tightening it down and then cutting the ends. Fabulous, solid, rock, holds it super well. But there was a problem. I started doing this on my pasta bridges, and what happened is I then noticed there was an issue. If you look on the left, that's my old style, using a knot and a SwiveLock. And on the right, that is the fully all sutured, knotless technology. Do you see a problem there? Because there's a problem there. If you don't see it, let me show you. So this is actually one of the patients that taught me there's an issue. This is a guy, this is a second look. I came in and I found that the suture was looser. He did heal. He healed on this side. The pasta was healed, gone. But there was a problem. On the other side, where there was never a problem, the sutures had cut through on my rotator cuff. And so unfortunately, there's a problem. So here, this is where you have the suture being held in with the SwiveLock. Comes out easily, no cut through of the tissue. But where it was interconnected on the fiber tack and I cut it out, that was a problem, and I now had a bursal-sided tear. But is this a problem with the anchor? No, it's a problem with the surgeon. I did a bad job, and I showed you how I did a bad job on that previous picture. The problem is that there's no looseness built into the system. There's no way it's going to loosen up over time. And so it's going to sit there and hold it tightly. So what happens is, if in fact you do this type of situation where it was so tight, it was compressing it down, you will strangle the tissue and it's going to tear through. So this is how I now do my pasta bridges with correct tension. It allows me to reduce the tissue down, but I'm not strangulating the tissue. And since then, I've had no further problems. The key is simply learning to do a proper surgery. As surgeons, we think that everything we do is perfect. And if something goes wrong, it must be the stuff we're using, as opposed to potentially our technique. And so the concept I want to talk about is this has ramifications on internal brace. That's the idea. That if an internal brace is going to be truly a temporary fixation, we have to build into the system some way for it to loosen up. Otherwise, it won't. Now, if you don't need it to loosen up, if you need it to hold forever, that's okay. That's fine. Like, for example, with Kevin, we saw that he was going to close a syndesmosis. Maybe that never needs to open up. Maybe that's going to be perfect for him. I don't know the answer because I'm not a foot ankle guy, so I'm not going to ever question him. But on my shoulders and on my knees that I do, all the internal bracing I do is meant to be temporary. It's meant to loosen up. So therefore, using a knot, a tied knot, which I know is going to loosen up because you know they don't last forever, or using a SwiveLock fixation, at least if I have one point in my system that can loosen, it will be okay down the road. Or I have to be careful not to make it too tight. So what does that mean for me? That's the first concept. The second concept is minimal surgery. Since I met Konrad Snarski years ago, and he taught me that ultrasound was the way to go, I've forced myself to learn the techniques that he showed me all those years ago and start to do innovative repairs. A lot of them internal bracing, and I've had the good fortune to have Gordon actually publish a paper with me on using ultrasound guidance for the MCL. The internal brace is easy to do. And as we heard from several of the people in the past 2 days, the MCL has broad attachments. So do you have to use ultrasound? You do not. There's no doubt it's not required for the MCL. The attachment points both on the femur and the tibia are so broad that you can choose where to put it and you're probably not going to be wrong. And as we've heard, if you're going to do it isometrically, that's something more you have to look at dynamically as opposed to anatomically. So I would argue for the MCL, it isn't as important, but unfortunately, my videos aren't showing up. There it goes. You can actually see that on ultrasound, you can see where the tears are. You can consider that if it is isolated, you can go in and do a simple repair as opposed to just doing isolated internal bracing or reconstructions. The thing about ultrasound is that you can use many different methods. You can use an in-plane method, an out-of-plane method, or a cross-hair method. And what it means is, if you do in-plane, when you put your needle onto the spot, you can see the needle being localized exactly on the anatomic structure you want. Out of plane, you're not going to see your needle, but you can estimate it's going to be directly underneath the center of your probe. And of course, the crosshair markings on that actual machine show you that X marks the spot is directly underneath. My argument is that if you have a very deep structure you're trying to get to and try to put an anchor into one spot, you're going to have to use the in-plane method because unfortunately, if you're off by a few degrees, even if you're directly over it, you may miss your spot. And sometimes you need to be anatomically perfect. So for the MCLs, I did publish that paper, but again, as I've said, not super important, but it just helps understand the concept. ALL, however, I think is very different. The reason why I say ALL is different is that the problem that I have with ALL, which it won't advance, there we go, is that the points are more point specific and getting the anatomic location is more important. And so understanding where you want to put it and being able to put it exactly there, that's something that ultrasound allows us to do. So here you can actually see where the insertion is directly on that point. There's always a small little bony outcrop where that ALL attaches. Now, if they're a younger patient, like in the teenagers, you're not going to see it. They haven't had time to build up that prominence of that where the tissue's pulling. But in someone that's older, in their 20s, 30s, 40s, you can almost every time see this little prominence where that capsular thickening is going to attach. And that's where the spot you want to hit. Likewise, there's been a controversy of where the origin is, whether it's anterior or posterior to the epicondyle, but the point is you can make it exactly where you want it. When I was doing ALL at first without ultrasound, I was having a real problem identifying sometimes where the epicondyle was with my finger. So this way you can see it specifically on your ultrasound and know where you're going to get to exactly. You can also sometimes see the tears directly, and you can see that right there. And of course, then what we do is we use the ultrasound to be able to identify exactly where the spot is, whether it's going to be an out of plane or an in plane, depends on your technique, but you can be essentially an absolute percutaneous, anatomic, and I do reconstructions, but as you've heard Gordon, he can easily just do internal bracing of that too. It's fine, but you can be point specific, so you don't have to worry about it. And what we've seen is it does in fact heal when you come back, as Gordon has said to us. MPFL. Now I would argue MPFL is probably one of the more important ones to do. Obviously if you're looking at the patellar insertion, that's something you could probably feel by yourself just using your finger. But the actual point of fixation has been difficult to find, and of course Philip Schottel has shown us the Schottel's point using X-ray and fluoroscopy. However, I would argue this is still very difficult and not easy to, whereas on ultrasound you can see it exactly, and you can be absolutely point specific and get to that with your needle. There you can see the MPFL going down to the femoral point. We can simply be able to find the adductor tubercle, move slightly distal to that, find that flat spot where it attaches. In fact, you can even see this person had some issues with the bone right at that spot. That little cystic change you saw there probably indicated previous damage to the MPFL in the past on this cadaver. But at this point, you can pretty much take your needle, and as you'll watch, I'll go ahead and put my needle directly onto that spot. The advantage here is that once my needle is where I want it, what I can then do is simply leave it there, take a small percutaneous incision, replace it with my guide, drill my anchor, place my anchor, and now I'm guaranteed I am anatomic in the spot for the MPFL attachment. It makes it very easy to do. So I can pick my spot of where I want to be. So I've also published on that for the MPFL repair or reconstruction. And of course, lastly, what I wanted to show you was PARS. Now, Kevin, I apologize. I am not a foot and ankle guy, but this is something that one of our foot and ankle guys in our area knew I was doing ultrasound and wanted me to show him how to do this, so I did. So I know about your PARS system. No, I don't do it. No, I've never done it. Sorry, except on a cadaver, just for fun. But I know that the biggest complaint has been how to make sure those sutures are exactly through the tendon dead center. Because what I've learned is, with the ultrasound, you can see the suture and the needles going exactly through to guarantee you're in the dead middle of the tendon. You have no guessing in this. In fact, what I do on this video is I even show how I can purposely, intentionally put the needle in the wrong spot. Here you go, needle's too low. That is not in the tendon. That's too low beyond, it's too anterior. So now I can just simply come out, readjust my guide, and now I can see that now the needle will go in the dead middle. This guarantees your PARS will always have every suture going through the tendon, never a problem. Very easy, very percutaneous, and very simple to do. And by the way, my guys in my area never publish, so you can be first to publish. Help yourself, you can have the video. All right, anyways, thank you very much.